what we have done so far and what are we planning to do. Hello, Ilke.
Hi, Dr. Nekofar. How are you?
Thank you very much. Nice to see you.
Nice to see you. Thank you for organizing such a wonderful meeting again. I'm sure that it will be great again.
Nice to see you. I'm trying to call Dr. Maryam Zanjir, the first author, to make sure she hasn't got any technical issue.
Maybe.
Let's see why she is not connected yet. Yesterday, I just confirmed, and I'm sure she is trying now to connect. Professor Miglani also connected. So I think we're almost ready to start in 2 minutes. Hi, Sanjay.
Hi, Sanjay.
Hi, good to hear from you.
Nice to see you guys, all of you. Thank you very much. We have Professor Kim, Professor Abu Tahun, Professor Ilke, and all of the colleagues. I can see Professor Meriç Kazandak as well, and Professor Iran Menesh. Many of my colleagues from around the world are connected, and my talented postgraduate student Fatima Hamidzadeh is connected as well, but we're just waiting for the first author, Dr. Maryam Zanjir. As soon as she is in, we may start, but we will start in 1 minute because I'm going to give some sort of introduction before we officially start. Fatima, you may call Maryam as well. I tried to call her. Please, you go ahead and call her while I'm going to start. Professor Abu Tahun, are you ready? Can we start?
Yes,
okay,
sir.
Professor Abu Tahun is connected as well. Hello. Professor Sanjay Miglani and Professor Kim, with the permission from all of you, I'm going to start our session. So, hello everybody. This is the 5th APEC, Asian Pacific Endodontic Confederation online journal club. And actually it is the 10th of Tehran University of Medical Sciences Journal Club. I remember that it was around a year ago when I was in our department and just discussing an online journal club with my postgraduate student. At the moment, I can say that it is around 25 years that I'm in charge for running and moderating the journal club of the endodontic department of Tehran University of Medical Sciences. And as many of you may know that between 2004 and 2011, I was honored to be in Cardiff University working with the legend Professor Paul Dummer. And at that time, after a year, from 2005 until 2011, I was in charge to moderating the journal club of Cardiff University Endodontic Department as well. And at that time, it happened in my mind to connect with my fellows in Tehran University. So we connect at that time through the satellite connection, which was a bit preliminary and primary with very low infrastructure communication. We just start working with each other at that time. And when we start reading the articles from International Endodontic Journal, I invite Professor Paul Dummer as the chief editor of the journal to be with us with our postgraduate student in Cardiff University. And we start asking him a lot of questions. We start asking him, okay, Paul, as the chief editor, why you accept to publish this article or that article with a lot of problems in that? And the answer was, it is for the sake of the publication, because we don't receive a lot of articles at that time, we have to publish most of them or some of them, obviously after a peer review. But some of those articles are brilliant, not all of them. And it was very difficult to mention such a things, that some of the articles are very good, some of them not, and what should we do? And it was the time that in Oxford University, based on what happened in Wales, in Cochrane situation, that people start appraising, people start criticizing others and criticizing the methodology of many published articles. That means that whatever is published is not going to be the best, or whatever is published is not going to be true. Maybe some of them had some conflict of interest or some bias or some problems. At that time, it wasn't very easy to say such a thing. But now we are very happy that according to this way or this approach, we can simply discuss the articles with each other. When I came back to Tehran and became the Tehran University of Medical Sciences professor again, I started doing same thing with my students. And it was an early morning that we have usually our journal clubs on Sunday morning. And the article that we were reading was the article published by one of my very, very close friends, actually very close Indian friends, as you know, Professor Gopi Krishna. And suddenly I told my colleagues, oh, I can call him and I can ask him to answer the question. Why not? And it was around 1.5 years ago. So I called Gopi. It was Sunday morning. He wasn't prepared because we haven't prepared such a things with each other. We didn't discuss such a things even with each other. And my students start asking their questions from Gopi. And then it happens in my mind, wow, what a wonderful approach. We asked the first author to join us and answer the question. And we put him on a very hot chair, asking a lot of difficult questions from him. And then after a short time, for the first time, and it was around the time of initiation of the pandemic, and everybody started using the satellite communication, the virtual communication, Zoom communication with each other. And it was the 10th and the 17th of May, 2020, that with the help and the presence of Professor Venkatesh Babu, we start discussing this article, Efficacy of Local Anesthetic Solutions on the Success Rate of Inferior Alveolar Nerve Block. And it was actually a systematic review. And did we carry that with a second journal club, which was calcium hydroxide, about calcium hydroxide, and discussed with these two brilliant Brazilian authors. And I remember that at that time, some of my colleagues start actually criticizing me, don't be harsh with the authors and be a bit more polite. And I say, I'm very polite, I'm trying to be polite, but this is the science. And in science, we don't have anything like that. In science, we discuss frankly and we criticize each other easily. And then we invite Professor Lars Brondel. He is one of the world authorities in the management of deep caries and exposed pulp. And we had actually 2 sessions with him discussing his article. We go very deeply about the details of the management of deep caries, which is, as you know, is a hot topic these days. And then we actually discussed with Professor Ibrahim Abu Tahun, who was the dean and the head of the educational committee of the Asian Pacific Endodontic Confederation, to start and signing and a memorandum of understanding between APEC Educational Committee and Tehran University of Medical Sciences. And it was my honor to start running the APEC International Online Endodontic Journal Club under the shadow of the Educational Committee of Asian Pacific Endodontic Confederation. And because it was the time of pandemic, it absorbed a lot of participants from around the world. And at that time, we discussed a very important article, which was about the associations between cardiovascular disease and apical periodontitis. And we carried that with this article as the second APEC online journal club, conservative management of mature permanent teeth with carious pulp exposure, with Professor Nesrin Taha from Jordan. And then we carried that for the third time with Dr. Sheldon Best from Canada. And he did actually a great job in a cohort study that we discussed about the methodology of that article at that time with Sheldon. And he was very humble and very honest about the methodology. So we discussed a lot with him. And Dr. Talal supervised Dr. Ahmad Abdullah, his postgraduate student, to present his article. And the way that we do that is we usually have a postgraduate student who presents the article, and then in the presence of the first author. And the last one was this one with Emmanuel Silva about the minimally invasive endodontic approach and access cavity preparation that my postgraduate student, Dr. Arvin Razai, presented that time. And we discussed that with Silva. And there we are today. We have Dr. Mariam Zanji. She's actually one of the great and talented PhD students in Canada, in Toronto University, working with Professor Azar Paju. And as I mentioned already, their article actually selected and awarded as the best paper in systematic review categories in 2020. And I asked actually Fatima Hamidzadeh, Dr. Fatima Hamidzadeh, my postgraduate student, another talented postgraduate student in our university, to work with me and to present Mariam's article. Before I ask Fatima to start doing that, I'm going to give you a short CV from Dr. Mariam Zanji. Dr. Zanji received her doctorate of dental surgery degree from Ajman University in 2013, from Ajman, United Arab Emirates. Then she moved to Canada. In the same year and started working as a college instructor with Canadian Business Skills College of Technology, teaching the medical and dental office administration program. In January 2018, she started her research-based Master of Science program in dentistry at the University of Toronto under the supervision of our colleague, Dr. Amir Azarpaju, that we are very proud to have our fellow Iranian professor in Toronto University. Her thesis focused on pain management during and following endodontic treatment. Out of her thesis, they successfully published with her research team 2 articles in the Journal of Endodontics that received award for being the first and the best published in 2019 and 2020. So she has already awarded 2 very important awards from Journal of Endodontics. Currently, she is pursuing her PhD studies at the University of Toronto with her supervisors, Dr. Amir Azarpaju, while being as an instructor for some of the undergraduate courses at the University of Toronto and Oxford College. Mariam, thank you very much for accepting our invitation. So before Fatima is going to have her presentation about your fantastic article, I'm going to ask you to just give us some word, and thank you very much for accepting the invitation of APEC. Please go ahead.
Thank you so much for inviting me today. It's a pleasure being here. It's still morning over there here in Canada, around 9 a.m. But
don't worry, in Korea, Professor Kim, the president of APEC, is here, and it is 10:30 Korea. So we are here
wow.
from around the world from 9 o'clock in the morning to 10:30 in p.m.
Okay, that's sweet. Yeah, I hope you don't be that harsh with me if you're saying that you're asking so many questions. I actually defend this article was a part of my thesis that I defended in April. And I just started now this summer my PhD degree. So I hope everything is still fresh. We'll be able to answer your questions. And it's my pleasure actually to see it being discussed, because that's the aim of producing evidence-based articles. We wanted to be able to reach to clinicians, and we're trying to bring the best evidence that's available in order to allow clinicians to have an evidence-based practice, because that's the whole point of research. We want to be able to translate it into a clinical practice for the best of patients' care. So yeah, looking forward to it.
Great. Thank you. Thank you very much. So before we go ahead, I'm going to ask Professor Kim, the president of Asian Pacific Endodontic Confederation, to give us an introduction. And then I ask Professor Sanjay Miglani, the new dean of the educational committee, to give us his talk. And then I ask Fatima to start. Professor Kim, please go ahead.
Thank you for inviting me here. It's good to have the online journal club every month. So it's maybe third time for me to join this chance. I feel every time it's very nice to talk about the journal contents and discuss our idea. So it should be continued. So maybe the new chair of the education committee, Sanjay, will help you. So it will be much better and better once we have this again and again. Thank you again.
Thank you very much, Professor Kim. Professor Sanjay, please.
Yeah, thank you, Dr. Nikufar, for inviting me. You know, it is always a pleasure meeting you, and you continue to do good work. Regarding this journal club, I just wanted to say something to the postgraduate students that most of us want to do research, but the problem is the research question. And when you discuss, you know, systematic review and meta-analysis, it not only gives you the credible evidence of what is available today, but also the lacunae which is there in the literature. So you can pick up a lot of research questions from these systematic reviews and meta-analysis. So actually, I was reading the article and I could find 3 of them. So I'm going to give them to my students. So my best wishes, and the PGs should be careful, and you know, you'll pick up many new questions which can arise from this discussion. My best wishes.
Thank you, everybody. Thank you, Professor Abu Tahun, for all of your help while you were the dean of the educational committee. And I'm going to ask Fatima to share her presentation, which is about the article published by Dr. Mayam Zanjir and her colleagues in Toronto University. Please go ahead, Fatima.
Hello, everybody. This is Fatima Amidzadeh. Do you have my screen? Dr. Nikufar, you are mute.
Okay, yeah, we can hear you very well, but please speak a bit louder and go to the presentation mode, please.
Okay.
Thank you.
Is it okay?
Yes, it is. Go ahead.
This is the 5th APEC and 10th TUMS International Online Endodontic Journal Club. It would be a pleasure for me to be the appraiser of the best paper of 2020 by Dr. Mariam Zanjir et al. The topic of the article, this review article, was efficacy and safety of post-operative medications in reducing pain after non-surgical endodontic treatment, a systematic review and network meta-analysis. It is published in 2020 in Journal of Endodontics. Dental pain actually is an unpleasant subjective experience reported by about 27% of patients. It is reported by 21 to 40% of patients immediately after non-surgical RCDs, and it may persist up to 6 months and more in 7% of the cases. There's a fact suggested by NG in 2004 that the presence of preoperative pain increases the incidence of postoperative pain. That means that preoperative pain is a significant predicting factor for postoperative pain. There are also previous network meta-analysis around this topic, not specifically this topic. First one by Professor Venkatesh Babu, that we have him here. It's a pleasure. And the others by Moore et al. And Smith et al. I will have a summary on these articles. The first article by Professor Venkatesh Babu is on efficacy and safety of oral premedication and pain after non-surgical root canal treatment, a systematic review and network meta-analysis of randomized controlled trials. This article was published in Journal of Endodontics. Within the limitation of this study, the author suggests that paroxysmal and prednisolone were recommended to control postoperative pain as pre-medications, not medications which are taken after the treatment. It is contradictory to the results of these two studies. First one by Smith et al., which was on non-steroid anti-inflammatory drugs for managing postoperative endodontic pain in patients who present with preoperative pain, systematic review and meta-analysis. This article suggested that NSAIDs, either with or without acetaminophen, are more effective than placebo to manage postoperative pain in patients who are undergone RCDs. And the other article, which is somehow an umbrella review, which is on benefits and harms associated with analgesic medications used in the management of acute dental pain, and overview of systematic reviews by Moore et al. And this article also suggests that NSAIDs are the most favorable group of drugs to manage an acute dental pain, considering benefits and harms of it. And the purpose of today's study...
Can I ask you to stop, because I have now a question?
Yes.
So although Mariam asked me not to be harsh, but I'm going to start my questions. Just joking, don't worry. What I can see here, you showed us from the article 3 different articles as the introduction, but I just wondered why these 3 articles in terms of the methodology are completely different from the title of the present article. And is it possible for us to compare them with each other, compare the result with each other? Because about Wenke, the article published by Wenke, I saw that it was actually about the premedication and about, because this one, thank you, efficacy and safety of oral pain medication and pain after non-surgical root canal. Yes, so it is about the premedication, not the post-medication, the one that we have seen in the present study. And also, if you go to the next, please. In the next one, it was actually about the patients that they suffered from the preoperative pain. And I was actually going to ask you a question about why we choose preoperative pain and what is the difference between when we have preoperative pain and we don't have preoperative pain, and what is the importance of this particular variable that comes to the title of this article. And the third one, which was completely an umbrella review and a bit different from the present study again, is about the side effect of the post-operative analgesic. So these three are completely three different articles. And what was the reason that in the introduction, they compare them with each other? I think if Mariam is going to answer, and then we come back to Fatima if she wants to add anything else. Mariam, please go ahead.
Yes, thank you for your questions. Actually, yes, they are three different, so all of them are different articles that had different because of questions. First, the main limitation is that what we conducted was the effect of post-operative pain. So when it comes to post-operative pain, there have post-medication, the effect of post-medications. And none of these articles, well, actually the other two meta-analyses they considered, but the network meta-analysis that was conducted prior, it only looked at the effect of pre-operative medications on post-operative pain. So the types of studies that were included are different from our studies. And while we looked at the effect of post-medications, so the medications that are given after endodontic treatment. And therefore, we had different types of studies included. We had different types of interventions. And that allowed us at least to get the overall pictures so that we would have some of the drugs of like from the other network meta-analysis and our network meta-analysis. Now, of course, to get the overall complete picture, probably like a future NMA, considering both of these types of studies and then running a subgroup analysis in order to explore the effect of, is there a difference between the administration of preoperative drugs versus postoperative drugs? Meanwhile, the other systematic reviews that were conducted, they had some limitations in the fact that first, they included different types of interventions. So the drugs were not only administered orally, some of them were administered by means of injections. And this is not a very common practice among a general dentists. And also they would, it would require some training, and not everyone would give that. So in our NMA, we wanted our result to be applicable to the everyday practicing dentist. We only included oral medications. So any study that had a medication given in another method or by means of an injection, we excluded that, and we kept it limited to oral administration. The other factor that we also considered was preoperative pain. So preoperative pain is considered to be a strong predictor for postoperative pain. And it was found that patients who walk in with moderate to severe preoperative pain before endodontic treatment as a result of irreversible pulpitis, they tend to suffer more, they have a higher prevalence of suffering postoperative pain. So we actually considered that as a factor, and we included all the studies, and we only identified one study where the patients did not have preoperative pain, but then we ran a sensitivity analysis, which is a type of analysis that you exclude the study with the factor in question in order to see, does it have an impact on your results? And for us, we only had one study. And once we excluded it, it did not impact our results. And but therefore, we didn't have high number of studies. So overall, the contribution of that study wasn't high to our results. Meanwhile, the other systematic reviews, they did not consider that factor. So either they did not report the preoperative pain, or they did not discuss that, or it was as a limitation due to not high numbers of studies being included. And thirdly is that we looked at the quality assessment of the included studies. For example, those that were judged to be of high risk of bias, we accommodated that by running a sensitivity analysis, which is a common practice among researchers in order to see, would that impact your results? And again, these systematic reviews, they did not accommodate for that. So even though they assess the quality of studies, but they did not look at the impact of these studies on their overall results.
Thank
I
you.
hope that
Thank you,
answers
Mariam.
your question.
Yeah, there is one question from Professor Miglani. Sanjay, please.
Yeah. My question is from Mariam, actually. Since I see your article is on medication post-operatively, actually, this is not regarding your article, but I submitted a proposal to the ethical committee of my institution comparing drug A with drug B in post-operative pain, where we use placebo as a control. And the ethical committee actually asked me to appear before it, and they asked me what is the incidence of post-operative pain. So I said 21 to 40%, as mentioned in your study. And they said you expect 40% of the patient to have pain, and still you want to give a placebo. So I didn't know what should be the control group for such randomized clinical trial. Can you throw some light on that?
Of course. So that's one of the implications of our paper, and is that we need to stop giving placebo. So there should be a shift between clinical trials that, like future trials, should consider NSAIDs as a control group rather than giving a placebo, because we will expect to see a change. We expect to see pain, and therefore, if you shift towards NSAIDs, we'll be able actually even to conclude, are the other groups considered to be more effective than NSAIDs, or are they less effective than NSAIDs? So that's one of the implications. But again, we did not give high recommendations in our paper because the quality of the results ranged from very low to moderate. And usually such recommendations need like a higher quality of the base knowledge in order to come out with such. But probably you'll find that, so my thesis still will be published probably end of June or July. I'm not sure when it's going to be uploaded, but you'll find that that's recommendation as well.
Okay, Sanjay, please.
Yeah. The issue is we were trying to do a randomized clinical trial in the patients where NSAIDs are contraindicated. So what gold standard should I use now?
So again, and that's another limitation in our trial.
I have a control group actually now.
So that's another limitation. So it depends on what group of patients you're looking at. So if it's the patients who are good to have NSAIDs, then ibuprofen is considered the go-to. Meanwhile, for those without NSAIDs, and we actually could not locate much trials in our NMA, and that was one of the future suggestions for trials, to consider patients who do not take NSAIDs. So according to what we found, or according to the current recommendations, acetaminophen should be considered for mild pain, while for moderate to severe pain, a combination of acetaminophen and opioids, or opioids is suggested in order to control that pain. Which type of opioid? Again, that was a limitation, that we could not explore the different types of drugs because we did not have enough trials. And if we are to just to conduct the, to try and explore that effect, the results will be imprecise. And we did not even identify much trials. So probably that's something for you to explore.
Yeah, that's what we were trying to explore, but I'm still looking, what control group should I use?
So again, depending on the pain levels, I would suggest probably looking into the literature for what's available out there, and for those who are sensitive to NSAIDs, maybe to start with acetaminophen and then go from there. But for others who are good to take NSAIDs, we suggested ibuprofen.
Mariam, what about suggesting to our participants in the study, I mean for Sanjay as well, just to tell them, if you have post-operative pain, you may decide to go for an analgesic, like if needed, PRN, or so then we may have placebo group and tell all of them, if the medication as the drug A, drug B, or drug C, which we don't know which one is placebo, then we can just give them permission to start using a known painkiller. In that case, if they start the use of known painkiller, we can put them in another group that the pain was severe, so they start using that. Is it, do you think, is it a proper methodology or not?
The only concern would be the variation between patients. So when would the patient expected to get pain? When are they going to have their doses? Are they going to be following the recommendations? So at the end, once you are going to collect data, it may not be as homogeneous between all the patients, and that may be a limitation. And therefore, what we recommend is that for such trials, start with patients with preoperative pain. If a patient does not have preoperative pain, then don't include them in the studies. And because we expect to see postoperative pain in these patients, and therefore we give them, we follow the protocol. So either to give preoperative medication or postoperative. And by the way, only like in our studies, it was only 1 dose postoperatively. So they did not continue with that drug. So only 1 dose and see what is more effective for patients. Because at the end of the day, we try to minimize medications, but at the same time, we want the patient to have a positive experience, and we don't want them to suffer from pain. And therefore, that will make your results even more homogeneous. So you can, if you want to have a placebo, you may have placebo, but again, based on studies, like placebo tends to be the worst, and patients, they do suffer from pain with placebo.
Especially when we choose the one that they have preoperative pain.
Exactly.
I mean, choosing the group with preoperative pain is make it more consistent, as you said. So as a take-home message from this part of the discussion, we may say to our postgraduate students or our colleagues, if they want actually to run a clinical trial, the very good idea is to choose the patients that they already have preoperative pain, even more than, for example, 5 or 4 in terms of VAS, and then go for the study if they want to compare different techniques or different medications. Because if they choose the one that they don't have preoperative medication, then the variables are not under the control of your study. Thank you very much. Very nice question. Very nice.
Yes, so there should be a dilemma, and that's an issue we're seeing in so many published papers right now. So the population need to be representative, but then if there's no dilemma, if you're including patients that do not have the factor you're studying, then your results are going to be as well biased. So that should be improved in the country.
Thank you very much. Fatima, carry on, please. And if there is any question anytime, please just raise your hand. Then we give you time to ask your question from Fatima or Maria.
Okay. And the purpose of this study was to
Fatima, please go to the presentation mode, please.
Isn't it presentation mode?
Yes, please.
Is it okay?
Not yet.
And
yes, now it is okay.
The study was to systematically review pharmacotherapeutic agents used in the management of postoperative pain in patients who underwent non-surgical initial endodontic treatment using an NMA approach. And the focus question was among adult patients who received non-surgical endodontic treatment, what is the most efficacious and safe postoperative medication to reduce postoperative pain? And the eligibility criteria.
Fatima, sorry, I want to again interrupt you. Yes. Can you go back to the previous slide? That's a very quick question. Fatima, can you go back to your previous? Yes. Mariam, you use pharmacotherapeutic agent rather than medication or drug. Is there any particular purpose for that, or it is just a matter of writing in a nice way? Pharmacotherapeutic agent, what is the difference between that and medication or drugs?
Well, it's just the terminology that we're using. This is a term that's probably more general, that would include different types, and especially we still did not conduct the search. So this is like a more general term to be used, and it includes all the medications.
Okay, thank you, Fatima.
May I continue?
Yes, please.
To summarize the biggest question of this study, the people included in this study actually are adult patients who undergone initial non-surgical root canal therapy. And the intervention comparisons are all the medications taken by them post-operatively, which were not antibiotics. The antibiotics are not included in this study because they're not suggested to use according to the guidelines. And the outcome, in the outcome, we have primary and secondary outcome. Primary outcome is the pain management, how the pain is managed, and the score of pain, which was reported by patients. And the secondary outcome was safety, which is reported qualitatively by patients. And the papers who just reported the secondary outcome were excluded too. And the study designs were all RCDs because this paper was trying to systematically review the randomized clinical trials. And it is reported based on Prisma. Here you can see the databases which were searched until July 31st, 2019. Only English studies were included. Gray literature also was searched for any more studies. And here you can see a diagram which I think is a bit different from what we can see in the paper. When we can see here, do you have my voice?
Yes,
Yeah.
very well.
Here we can see that the authors suggested a total of 45 records were screened, but in full text. But here we can see it was 19. I don't know, maybe I'm wrong, but please discuss this if these numbers are related to each other or it is.
Mariam, is it just a typo or something else? Because in the diagram, as Fatima mentioned, in the diagram, the number of full text article assessed for eligibility is 19. However, in
also, I'm sorry, 758 records were excluded based on title and abstract according to the text, but records excluded according to title and abstract here are 784. 758.
Yeah, probably that might have been a typo. So the figure is actually the final that were followed. Thank you for noting this out. Yeah, I'll make sure to correct it.
But okay, actually, only 11 studies, according to the text and this figure, were included in qualitative and quantitative synthesis.
But I'd like just to add a comment. So for the types of studies that were included, we considered our search was very broad and we did not restrict it to language. At the end, we only included the English language because that's what met our eligibility criteria. But we had studies from other languages that we actually did the translate in order to look, are they meeting our eligibility or not? Because if you're only limited to an English language, your search from the beginning, so that would be a limitation for your study.
Yes, I actually saw an article which was in Persian, Farsi, on antibiotics, and I was somehow.
Yeah, we found one, yes, but it did not meet our eligibility criteria.
Yes, it was
because they introduced antibiotics. Yeah.
Yes, yeah. And the population which was finally included in this study were about 706 adults. Age range was between 18 to 68-year-old. Pulpal diagnosis was done by thermal tests and EPT and based on patient symptoms in some studies. Pulpal status among the population included were irreversible pulpitis and necrosis. And the periapical diagnosis was as follows: apical periodontitis, acute apical abscess, and normal. And all trials recruited patients with moderate to severe preoperative pain, except one that recruited asymptomatic patients. The interventions included were among these 11 studies were 8 interventions in 8 groups. First group NSAIDs, second one NSAIDs plus acetaminophen, the third one NSAIDs plus benzodiazepines, fourth group NSAIDs plus opioids, fifth corticosteroids, sixth opioids alone, and seventh acetaminophen, and eighth placebo. Outcome assessment was done based on a 100 millimeter visual analog scale. In some studies, this scale was used, and in some studies it was not used, but the scale used was converted to this scale in order to unify all the results. And then to assess risk of bias, they used risk of bias tool of Cochrane. And here you can see in the picture that the most concern of bias is in random sequence generation and allocation concealment. But there are some risk of bias in blinding of participants and personnel and blinding of outcome assessors.
Fatima, I have a question from you. Can you tell me what is the difference between this random sequence generation and allocation concealment and blinding of the participants? Because blinding, allocation, concealment are very close to me. Can you explain a little more about that?
Random sequence generation and allocation concealment, as you can see in the picture, have to do with selection bias. And this means that in random sequence generation, we just it is about a randomization of the sample, and to randomize the sample to have a sample which is a representative of the population and these factors. But in allocation concealment, you try to conceal the allocation of each of the participants of the study to each intervention. This concealment is important in just because of selection bias. If you know that you are allocating this participant to this group of intervention or that one, it may be a source of selection bias. Mm-hmm. But blinding of participants and personnel and also assessors is another issue, which is in when you are trying to give the, for example, you give the intervention or just doing the operation. Here it is an intervention, which is a drug. It can be blind. Even the one who is giving this, prescribing this medication can be blind, but sometimes it is not possible to blind the personnel, for example, when it is a surgery versus a drug. And,
okay, thank you very much. Mariam, do you want to add anything for the answer to this question, the difference between allocation concealment and blindness?
I think Fatima did explain it well. The whole idea of allocation concealment is that once you did the randomization for patients, we want to ensure that the the operators are not aware of this allocation. So they did not know who actually will be receiving each treatment, while for blinding of the personnel is during the treatment itself. Are they aware of the type of treatment? Usually if there is like very proper allocation concealment, and as well, because sometimes the intervention that you're actually giving, you may be able to tell, for example, the injection technique. And that's such, in order to blind the operator, it's impossible to blind them. So either you'll have a different operator to come and give you the injection technique, or you'll have a different outcome assessor, so that things are not biased.
And I understand also you exclude the articles that they don't explain the power and the sample size and the way that they calculated the sample size. And I couldn't see that in the risk of bias assessment, any information about that. Can you tell me why you exclude those articles that they didn't mention the way of the sample size measurement in their studies or sample size calculations?
Actually, we did not exclude the studies that did not mention the calculation, but we excluded those that did not report the number of the sample size, because we need the final number to run the analysis. And that's like one of the recommendations of Prisma, is that authors, they need to report their sample size. But if they're not reporting to me how many patients are within each group, that will be a limitation. I won't be able to get the data and run the analysis.
Okay, understand. Thank you. Yes. Okay, Fatima, please.
Here you can see the network, which is given the article. The picture A is for a 6 to 8 hour interval, B is for 12 hours, C is for 24 hours, and D is for 48 hours. The nodes are each medication, and the lines represent, each line represent the one study, and these lines together make thicker lines. And when a line is thicker, it means that more studies have studied this combination.
All right, so you mean when it is thicker, that means the number of studies are more than the one which is thinner.
Yeah.
And therefore, for example, looking at, because this graph, I really love this graph, because this graph is it is the heart of the network meta-analysis, I believe. And for example, for number A, I can see that NSAIDs and placebo, obviously, this is much, much thicker than others. So that means in most of the studies, there is a comparison between NSAIDs and placebo. Am I right?
Yes, this pair.
Okay, so but I cannot see sometimes any line between some of them. What does it mean? What's the meaning of that? For example, between acetaminophen and opioids, there is no line. Or between NSAIDs plus opioid and corticosteroid, there is no line. What does it mean?
It means that there was no study who directly compare this pair, for example, acetaminophen and opioids.
All right, and some of these lines are gray and some of them are black. Is there any difference between them?
That was the question of just being thinner or thicker. They're all black lines, some of them thinner and some of them thicker.
All right, so when they are thin, they become gray.
Yeah.
All right, understand. Okay, that means there's just one study, for example, between acetaminophen and placebo. Am I right?
Maybe.
Okay, am I right, Mariam?
Of course. Now, the thickness, that will represent the number of the studies, and that just gives you how much studies are actually comparing these treatments. Now, and then here comes
can we say that we don't have enough study for running a network meta-analysis like that? Isn't a bit early for you to run such a study and publish it, you think?
Not really. So there is no limitation. As long as you have the 3 treatments, then you can actually run a network meta-analysis. And the question is, do you have or not? It depends on your results. Are they precise or not? Like once you run the network meta-analysis, you'll be able to see first, did the like the analysis did the model fit and did it converge? Was the data reliable? So there are many like steps in the analysis that would tell you that this is legitimate and the results are valid for network meta-analysis, and sometimes there'll be threats actually to your inconsistency, and there would be some heterogeneity. We did not find such significant effect, and therefore it was valid. And I want to add that this figure represents the advantage of network meta-analysis, because even though, for example, there is no line between acetaminophen and opioids, we could indirectly get the effect of that treatment, and that's one of the advantages, to get indirect treatment effects of treatments that were not compared directly. And that's with the NMA.
Can you describe that? Can you describe this indirect comparison?
So, for example, in this, the figure A, where you have acetaminophen and opioids, they were not directly compared, but in network meta-analysis, we could get the effect between them by subtracting. For example, if you look at the whole triangle, opioids, acetaminophen, and placebo, we could actually get the effect of acetaminophen versus a placebo, acetaminophen versus opioid, by subtracting the effect between opioids and placebo, and acetaminophen and placebo. And that will give you an indirect effect, which will be compared for other direct effects in order to tell you, are the evidence agreeing or not? So here we don't have a comparison, but for example, by other treatments, there is a comparison, and we still estimate the indirect effect to see, is the direct and indirect evidence are agreeing? And that's to test for validity of something called the inconsistency of network meta-analysis, where we actually measure like different nodes in order to be able to tell, is the evidence agreeing? And we did not identify any significant threat, which meant our results reliable.
Great. And do you think, is it powerful enough to go to the conclusion when we don't have direct comparison, just go for the calculation of indirect comparison? Is it powerful enough to use it clinically?
Not really. So it does gives you some evidence, but at the end, once we're rating the evidence based on a grade, the evidence will be low. But it may be something to consider for future trials. Like if you find an indirect evidence that appears to have a very large effect, then that would be a question to consider for future trial.
Great, thank you. Thank you very much, very informative. Okay, Fatima.
And this is a summary of the results for each interval. I have something like this slide for each interval. Here you can see a table, for example, for at 6 to 8 hours. We have a table. Each of the eight interventions are here included. The orange arrows are for the interventions which were not significantly different from placebo. And here for this interval, you can see that only NSAIDs plus acetaminophen and placebo were those we compare. And they are like this in order. Placebo was the least effective, then NSAID, and NSAID and acetaminophen was the most effective intervention for this interval.
Okay, Fatima, what does Sucra means here? Because in the table we can see SUCRA percentage. What does it mean?
Yes, Sucra stands for the surface under the cumulative ranking curve, which is something that we use. I don't know if you remember rankograms. We try to have some graphs for each intervention, which the surface under the graph tries to indicate the percentage and intervention is on the top rank or one of the top ranks. And when this percentage is more, it means that it has more chance to be the toppest rank of in a group of interventions. For example, here you can see NSAID plus acetaminophen is 73%, which is it means that it has 73% chance for to be the toppest rank, and you can see it is the toppest rank here.
Right, and then when become,
but it is not just important to have this rank, also it should not, the credible interval should not cross the no effect line. The others which are excluded from this interval, for example, NSAID plus benzodiazepines and other groups with orange arrow, are the interventions whose credible interval crossed the no effect line.
Yeah, but I couldn't biologically describe why, for example, corticosteroids alone, they don't have any effect on the post-operative pain in comparison with placebo.
No, it is. They are the interventions which are not significantly different from placebo. For example, corticosteroid with placebo is not significantly different from it. You know, the orange arrows are the interventions which are not significantly different from placebo.
I know. So, for example, in this one, we can see that opioids, there is no significant difference between prescription of opioids and placebo. Am I right?
Yes.
But when it goes to corticosteroids, because we know that they have anti-inflammatory effect, I couldn't biologically describe that for myself, because when we prescribe corticosteroids, we are expecting to receive at least the result. However, in terms of the side effect, we may not prescribe them straightforward as the first medication. But biologically, I couldn't find any reason for that. Is there any description for that, Mariam?
Well, actually, that's what the data is telling us. So even though when you look at the credible intervals, the mean difference was still high, though it's not as, like it did not reach for NSAIDs. So if the credible interval for NSAIDs was -21, the mean difference actually. Meanwhile, for corticosteroids, it was -15. It's still less, but then what's the data telling us? The effect of corticosteroids was insignificant. Meanwhile, NSAIDs were more effective, and that's even a call for clinicians to start, and that's based on also the current recommendations. So start with NSAIDs. Don't expose the patients to corticosteroids because the long-term effects of corticosteroids are worse for patients. So it's always best to start with NSAIDs, which is considered to be a safer approach. Now, again, that's what the data is telling us. Our confidence in our results may be changed if we have more trials. And that's as well was different from the other NMA that was conducted on preoperative medications that actually found corticosteroids to be effective. So it always depends on the numbers of studies that were included, and that reflects, and the data as well. So we did not have much on corticosteroids, but the question is, do you want to put the patient at risk and prescribe them corticosteroids when NSAIDs have proven to be effective?
And what about NSAIDs plus opioids? Because we are again expecting when NSAIDs alone, they are effective. When we combine them with opioids, at least they should have similar effects. Why NSAID and opioids, they are again insignificant?
So that's what the data are telling us. Probably there isn't enough studies that that actually investigated the effect of both NSAIDs and opioids, or even NSAIDs and benzodiazepines.
Because what am I trying to say, Mariam, is when the data is not in accordance with the biologic correlation or biologic consideration, should we put some sort of doubt about the data and try to produce more data or more valuable data for the future or not?
So, of course, what we have here is a representation of the evidence and of the publications so far. So that's what we have in the research in endodontics. We were limited, of course, by the number of studies that are included in both of these groups. And therefore, maybe it did not reach to the level of significance. Meanwhile, the highest number of studies were actually investigating.
Yeah, so if you agree, I like actually to ask this question from all the audience or my colleagues and professors that are here to tell me their opinion as well, because usually I prefer to have some sort of backup information from the biological correlation rather than just the data and numbers. Because if I know that NSAIDs are going to affect, but why not NSAIDs plus opioid? I'm not saying NSAIDs plus opioid is good. I'm just saying that when NSAID works, why NSAID plus opioids, it didn't work. So Professor Abu Tahun or Professor Sanjay or Professor Kim, Professor Bakhtiar or others, if you want to add anything to that, any of you, please. I don't want to mention all the names. If anybody wants to add anything to my idea or answer my question, or just tell me if I'm wrong, can we really rely just on the number and on the data? Or do we have some sort of background knowledge that we can add it up or not? Sanjay, please. You start the discussion and please others help as well.
Yes. Nikufar, you are right. You know, on one side, we have evidence and number, and on the other side, we have our clinical experience. So if you ask me, in my clinical practice, I still prefer to give NSAIDs with acetaminophen because I personally feel they act better. Yeah, you're right. We have numbers and evidence on one hand, and other side, we have our clinical experience. So we need to keep this also in mind. Maybe Dr. Tahun can come in on this.
Mm-hmm. I would personally agree with Dr. Sanjay. From our clinical experience, this is what we actually do. We ask our patient to take the NSAIDs, and if there is any pain, he can eat even Panadol. The other thing that surprised me is the effect of corticosteroids. From our clinical experience, we used to prescribe corticosteroids when patients have severe symptoms, and we always witness decrease and disappearance of symptoms after corticosteroids. They never let us down, and I'm really surprised by the results in this study are contra to our knowledge and our clinical practice. I can't explain that. I don't know if Dr. Mariam.
Yeah, I just want to raise this subject. This is very important because some people.
Me, Dr. Sanjay, everyone here.
Yeah, so people want actually to rely on the evidence, on evidence base, and evidence base is very important. But on the other hand, evidence base shouldn't be the enemy of our knowledge, shouldn't be the enemy of our biological knowledge and background knowledge. So I want actually to just initiate this discussion. I do have my own opinion, but I don't want to mention that. Sanjay, please. And others, please. Hang on, you help us as well. And then after that, Ilke. Sanjay first, please.
Yeah, in my personal experience about opioids, I prescribed it to a patient 17 years back, and he had to be admitted in the emergency. So it's been 17 years, I have not given opioids to any patients actually. So, and like Dr. Tahun was saying, yeah, maybe once in a year or so, we do give steroids to our patients, and they seem to work.
Yep. Ilke?
Okay, and I think in the included studies, if the analgesics were used prior to the endodontic treatment, the results would be different because maybe there would be significant differences between the placebo and the opioids and the non-steroid anti-inflammatory drugs in this case, because I want to emphasize an additional tissue. And with using premedication and analgesics in patients with high pain, our first aim is to inhibit the hypersensitization of the neurofibers resulted from the inflammation. You know, hypersensitization. We first want to inhibit them, the hypersensitization, because the main reason for pain is inflammation and hypersensitization of fibers. And I think this issue should be emphasized in the discussion more. And using such analgesics before treatment is more effective than using them after treatment. Then I think the main problem is this with the included studies. And you also say this in first introduction part. I think premedication, if the included studies use the analgesics prior to the treatment, the results would be different, and there would be differences, significant differences between placebo and the other drugs, I think.
Okay, thank you, Ilke. Mariam, please, you go ahead and answer Mariam first, and then there is another question. I will read that one after that. What do you think, Mariam, about my question, Sanjay comment, Abu Tahir comment, and Ilke comment?
All right, those are all valid. Remarks. Now, the issue is even though corticosteroid may result in a significant pain reduction, and especially that the time of the administration, so preoperatively, it showed that it was actually effective. There are two factors to consider. First, the number of studies that were included. So how much data are actually contributing to the overall results. So that's something that may affect the overall conclusions. And the second thing, even though if corticosteroids would work, then there's no, even NSAIDs would work. So NSAIDs and actually are more focused towards an anti-inflammatory outcome, and the fact that it's safer for patients. And as Dr. Sanjay said, whenever it's like even if you add acetaminophen to it, you'll get the advantage of the addition and more analgesic effect for the patient. So the NSAIDs plus acetaminophen has proven for a long time to work against moderate to severe pain. So why to expose a patient to corticosteroids rather than a safer approach? We're very optimistic with the results, because it may shift the practitioner's practice from prescribing corticosteroids and putting patients at risk of all the side effects that are associated with corticosteroids, when NSAIDs, which is considered to be the first line of treatment recommended by ADA and all the current guidelines, has proven to be a safer approach. So corticosteroids may be like reserved for other conditions, for example, asthma, or when the inflammation is more generalized, and like for other indications. But for a dental use, maybe we can reserve it at least if the patient has shown to like no response to NSAIDs, which is the first line of treatment, then maybe we can jump to corticosteroids. But always like start with a safer approach, because your patient may improve from from NSAIDs. So why to put them at risk? And even opioids, the current crisis on opioids and its dependence, and even the pain mechanism of opioids, it just targets the pain receptors, but it does not target inflammation. So why as well to prescribe opioids, which is, again, we were as well very optimistic and very happy with our results that opioids were found to be ineffective. And because the pain from irreversible pulpitis is inflammatory in nature, and in order to target this pain, you want to decrease the inflammation in the area. So, and NSAID has the advantage as well of having an analgesic effect, not only an anti-inflammatory effect. And once you combine it with acetaminophen, which has the analgesic effect, then you're actually targeting the source, and you'll help to alleviate the patient's pain.
And what about the premedication, as Ilke mentioned? What do you think about that? Because premedication, because Ilke suggested that can be discussed more in the discussion part, maybe, to say that if we use premedication, it may have more effect comparing the one.
Also, by this way, we also increase the effect of local anesthetics. It's important. It's another important issue. The effect of local anesthetics also, we enhance it by using premedication.
Yep.
Yes, that's a very good point, actually. In my previous network meta-analysis, which was on the efficacy on local anesthetic strategies, we found that the addition of NSAIDs would actually improve the outcome of anesthesia. So that's something to consider. Our NMA only focused on post-operative medications because there was an NMA on previous operative medication. So I think the difference between both approaches would be possible to investigate by conducting a larger network meta-analysis where we're putting both the studies into comparison and then see, is there an effect for the time of administration? That was a limitation we could not investigate, but it's something to consider for future.
Okay, thank you. And also, Dr. Negin Firouzi wrote a comment. She said that the quality of evidence of the studies that included corticosteroids are very low. Could it be related to this discrepancy in the results or not?
Well, unfortunately, the majority, I'll tell you, the majority of the studies in dentistry will produce to you quality that is very low. So even the other NMA that produced that actually concluded corticosteroids were effective, the quality of studies were of the results were very low, and they had a significant heterogeneity as well in the direct effects comparisons. We did not identify heterogeneity in the direct effects. So all of that will put for you, will raise question marks. So once even you look into a study, especially if a clinician does not have that much background when it comes to studies appraisal and looking at the quality of the evidence, many studies are telling us, yes, steroids are effective, but they're limited by the fact that the small sample size, and they're limited by the quality, how was the studies conducted, their methodology. So we can't just change our practice based on one clinical trial, and therefore meta-analyses are considered to have the highest hierarchy of evidence because we're appraising the papers that are actually published. And everything, I'll tell you, everything is very low. Does that affect? Maybe it has an impact on the results, and maybe not. Maybe actually we should just focus on NSAIDs because it's more specific toward this type of pain.
Yeah, thank you very much. I think this is very good, the take-home message from today also to our young fellows and our future researchers, that still be happy because so far the quality of the research is not good enough. And you have a lot of space to work and work and work. Don't worry about that. So the future is yours. Okay, Dr. Bakhtiar, please go ahead. You have some comment.
Hi, Mariam. Nice to see you. I do agree with Mariam. I think what we have here is the data, and we have to rely on that. And because we don't have enough well-qualified papers on combination of opioids, for example, and narcotics with in combination with NSAIDs, since they are not our first choice. Yeah, I mean, when we go back to the clinics, the opioids are not our first choice, and they go to the end of the line. So that's why the data is showing this, and we have to, rely on our data.
Okay, thank you very much. Fatima, please carry on. If there isn't any comment, if any of the colleagues, you want to have any comment, please go ahead.
Yeah, please, can I say just a few words?
Yes, please, Professor, please.
We don't disagree with Dr. Mariam. What we want to emphasize here is that opioids and corticosteroids should be considered as first line to combat pain. They should be preserved, of course, for severe cases. We agree on this. And we start with her strategy. Her strategy, we know it. It's very well known, and we use it since years. We start first with the NSAIDs, and after that we add something, and if we fail, then we go to something more strong. This is what I want to emphasize, especially for dentists who follow us. Not this dilemma, but this dilemma is very clear now to everyone. We don't start, of course, no one starts with corticosteroids. We preserve them for severe conditions. We start, as you mentioned, Dr. Mariam. We all follow this strategy.
Yeah, that's actually what we highlighted in our papers. So yeah,
Okay.
to reserve corticosteroids for after like when NSAIDs and acetaminophen would fail, and then we would go for.
Because the fact is that they work.
Yeah,
They work. We have seen this in our practice. I don't know. They work a lot.
Yeah, but true. Yeah.
Thank you. And Professor Androbi, Professor Mukhtar Androbi, you raise your hand. Please go ahead. Please turn on your microphone.
Oh, sorry.
Yeah,
hello?
We can hear you. Please.
I would like to add one thing regarding opioids and the use of corticosteroids. You see, what we have to go to actually the biological basis of the pain, the endodontic pain, the biological basis of pain is inflammation. So we have to focus mainly on anti-inflammatory effects of the drugs. And when we see opioids, they don't have the mechanism of action of opioids is centrally acting. They are not anti-inflammatory. So that's why we can't take opioid and taking into the risk-benefit ratio. Opioids have more side effects associated with them if we are using them as our first line for management of endodontic pain. So that's why NSAIDs are more effective, and corticosteroids do have a role. And as I can tell you from my personal experience, in certain severe flare-up situations, I have seen corticosteroids, the prednisolone, methylprednisolone, work very fantastically. Although we have less evidence right now regarding that, but maybe in future, prospective studies may be conducted in this direction, comparing the effect of corticosteroids as well as the NSAIDs. And then we can get a better evidence in regarding that. But the main thing is that inflammation is the main reason for endodontic pain, either pre-medication or post-medication. The aim is to reduce the inflammation. So the mechanism of action of NSAIDs is they actually have an anti-inflammatory effect. You see, what is the mechanism for post-operative pain, for post-operative inflammation? It's the complement system activation and the classical inflammatory pathway. And in both these pathways, the complement system and classical inflammatory pathway, NSAIDs have a role. They have a role of blocking these pathways. That's why NSAIDs are more effective in reducing the endodontic pain.
Thank you very much. But what I want to emphasize, and I want actually to conclude from this discussion, or if there's anything else, please, others, help me for that. But I want to emphasize on this. When we rely on evidence, when we rely on data, we need to be very careful, because data is going to tell us something that maybe we cannot find the reason or biological correlation. What am I trying to say exactly, as all of you, Professor Abu Tahun or Professor Androbi mentioned, that is, okay, we have an inflammatory disease, so we need NSAIDs or corticosteroid to go ahead and stop actually this inflammatory chain. But evidence tells us something else. Evidence is going to tell us, according to this amazing article, it shows that corticosteroid is not going to significantly work comparing to placebo. So this is not biology. This is just evidence, and we need to be very careful. Evidence is going to tell us much, much higher information comparing to what we have in our mind. Because if you compare NSAID with corticosteroids, then you may say that, okay, both may work, but corticosteroids, they have side effects, better not to use them, go and use NSAIDs. This is biology without evidence. This is not enough. We need evidence that somebody like Mariam already produced that for us and tell us something like that, okay? Evidence show that NSAIDs are superior to corticosteroids or even to opioids. So don't use them because evidence showed that, not biology, not what we think as just theory. That is the most important thing. That Mariam, what do you think? Am I right?
Of course. Now, even NSAIDs, like biologically, they do work. So they're considered to be like the most effective when combined with acetaminophen. And as you said, corticosteroids, biologically, they should work. But then the evidence did not reach to a limit to show us it's working.
Yes.
So, but I think in a clinical setting, when you're actually trying everything and it's failing, then maybe you can consider it afterwards. But always go for a safer approach. That's what we're aiming through our paper. Start with NSAIDs, start with something safer for a patient. Combine it with acetaminophen. It has proven to work. And this is the current recommendations
Actually,
of all the bodies.
That's what
Okay,
I said.
Mukhtar, you go ahead.
I said that NSAIDs are the first line,
Yes.
and corticosteroids also have the same mechanism of action. But while we are deciding between two drugs, we have to check for the risk-benefit ratio. The risk-benefit ratio favors more NSAIDs because there are more side effects associated with steroids. And also, but going according to the evidence, since most of the studies have been conducted evaluating the effect of NSAIDs, and studies conducted evaluating the effects of corticosteroids are less and are of less qualitative evidence. That's so we cannot take them as first line, but there are opportunities for conducting future research, more elaborate studies with greater sample sizes, comparing the effect of NSAIDs or corticosteroids and both. But at the present best evidence, NSAIDs plus acetaminophen is our best choice and as a safe choice as well.
Yeah, I want to add something.
You are right. Definitely, you are right. But the only thing is about the methodology. What I trying to emphasize is the priority of evidence over biologic or over what we think or our background knowledge. I'm a bit old school, but I try to improve myself about thinking methodologically. So we need to think methodologically. And I prefer actually to say that my opinion is this medication is good. Yes, I do agree with you. Definitely you are right. But you are right based on the evidence, not based on the biological consideration. That's what am I trying to say. Haki,
I want to add
Professor
something.
Haki Sunay, please, you also tell us after Mariam's opinion. Mariam's, go ahead.
I want to add something with regards to the number of studies. We had 2 studies comparing corticosteroids, and we also had 2 studies comparing NSAIDs and acetaminophen. So it's not like, even if we add more studies, as I told you, it may change the evidence and it may not. Considering my previous NMA, we actually found that investigated the different local anesthetic techniques. We found that IO using Artican to be an effective treatment, even though there was no direct evidence. So that was an indirect evidence. The direct evidence was more focused on IO using lidocaine, and that was significant. But then IO plus Artican was actually significant, even though it was not directly compared with IEMB. And that's just something to keep in your mind, that if a treatment is really going to be significantly effective, it may still show, like based on the data and based on how many patients had a successful pain relief, it may still reach and show itself to be as effective. But compared in this type of pain, it did not reach that level of significance. So we still have something to rely on. The evidence, yes, it's low, but it's something to keep in your mind. Like most probably pain, NSAIDs plus acetaminophen would work. And if it does not, then NSAIDs, again, if you give more NSAIDs later, like in another time period, then it may still relieve patients' pain.
Thank you. Professor Sunay.
Hello, everyone. It's so great to see you all. I'm sorry I was able to join you a little bit late. I mean, like 1 hour late, sorry. I'm trying to catch up with your discussion. So I don't want to, this quality is really going well. And fast. The only question in my mind, let me ask that. So maybe it can give us another way of thinking. What is the variant there? This is, I mean, you know, we have the medicine and we have the formula, we have the case. And what is the difference in those ones? The patient. So is the patient, what is the position of the patient in our decision making on these prescriptions. Actually, in these cases, maybe I don't know if it was discussed before, but when I'm listening to this discussion, the only thing which I cannot answer is the patient's reactions. It's all different, and how can we, when we're planning such a study, how do we set the conditions, and how can we standardize, make it standard? Actually, these are the questions in my mind. And in my cases, in my clinics, I always, if I'm going to prescribe something, I'm just trying to really understand the person which I'm treating. So the formulas are, of course, they're good, but it always changes by patient to patient. That's all I can say, because really,
Yeah, good question. Thank you very much, Professor
I was with you later, sorry.
Thank you very much. Mariam, I think the question is going to, if you make it a bit wider, you may speak about the multivariability of pain studies, because I know you are running a lot of studies about the pain, preoperative, postoperative. If I somehow expand what Professor Sunay mentioned about the multivariability of pain, can you explain a little more about that?
I think he presented a very good point. The fact that first you have to put the patient in the picture. So your care should be more patient-centered, and patients, they should be aware. So what type of medication that you're prescribed, you should always present as well the information to patients. You should tell them the evidence. You should tell them the associated side effects, like if this drug is associated with those type of effects and the others. You should let them be involved in the decision making, and not just take the decision and give it to a patient. You should allow them to as well to know what they're actually taking, and that will make the patient as well more satisfied with the treatment, and it will improve as well your outcome. Once you explain to patients the type of pain they're having, the source, and the type of medication you're giving them, all that education may play a role in the desired outcome you're looking for. And yeah.
Thank you. Fatima, please share your presentation and carry on. We go back to the discussion. Thank you very much for the amazing questions, amazing comments. Thank you very much. Very informative. We can see your
next
slides.
Interval was 12 hours after the treatment. In this interval, as you can see, again, NSAIDs were the only intervention which was effective. And at 24 hours, again, NSAIDs were the only intervention which was effective. But in the first sensitivity analysis, in which they excluded the study which recruited patients who did not have preoperative pain, it showed to be effective in the group NSAIDs plus acetaminophen. Maybe if your patients have preoperative pain, NSAID plus acetaminophen could be effective. To summarize the results, the best, the most efficacious intervention in each interval are as follows: at 6 to 8 hours, NSAIDs plus acetaminophen; at 12 hours, NSAIDs; at 24 hours, NSAIDs; and at 48 hours, no treatment resulted in significant pain reduction. The qualitative data indicate that 17.6% of patients taking NSAIDs in 3 studies experienced headache or drowsiness, and 9.9% suffered from GI symptoms, including emesis or nausea. And firstly, I discuss this part, and then I go to the other parts. As you could see in the results, if you want to be active, try to be active in the first few hours and first 2 days. NSAID plus acetaminophen was the most efficacious intervention, as you could see in first 24 hours. But the authors discussed that no specific NSAID is proved to be the most efficacious one. Maybe we have more studies on ibuprofen, but not enough studies on other types of NSAIDs. NSAID plus opioid was not significantly different. It was a good news because the authors suggested that there is an increased prescription of opioids, which is in United States, which caused widespread misuse and related overdoses, accounting for 40% of United States overdose deaths in 2016. And that's the good news, not to prescribe these drugs for the first line. No major safety concerns were reported in the included studies. And as I mentioned, ibuprofen is the drug of choice if the patient is experiencing a mild pain. 200 to 400 milligram of ibuprofen can be prescribed. For moderate to severe pain, 600 to 800 milligram ibuprofen or 600 milligram ibuprofen plus 1000 milligram of acetaminophen. Just try to check it with the patient's weight. The subgroup analysis was conducted to check which intervention is better for the group of patients which cannot take NSAIDs. NSAID is contraindicated in them. The results show that no significant pain reduction was observed at 6 to 8 or 24 hours. And no data on pain reduction at 12 or 48 hours. I think this is a bad news. In this subgroup analysis, tramadol 100 milligram was assessed, and it was not significantly different from placebo. The writers suggest that acetaminophen plus opioids should be investigated more in the future studies. And because we don't have any other choice, maybe we should just stick to this guideline by Hargreaves and et al., in which we can see acetaminophen for mild pain and opioids or opioid plus acetaminophen for moderate to severe pain. And corticosteroids resulted in no effect on pain reduction. This is contradictory to Professor Venkatesh Babu's study. As Mariam said, the small number of studies included in this study, the moderate to very low quality of evidence generated, the significant heterogeneity in the direct evidence estimates may be the cause of this contradiction to our results. And also there is another point that they used this medication preoperatively, not postoperatively. The critical point, which is not considered in some studies, that we are not allowed to prescribe this group of drugs for long durations and in high doses. And they are an appropriate adjunct to dental treatment when no other anti-inflammatory medication has helped and no signs or possibility of developing is observed. two amazing, I think, point was we have some studies which had overdoses. This one and this one, they had some results which were discussed up to now in the results, but the nice point is that they had an overdose according to the guidelines, but they are published. Antibiotics were investigated in 3 studies. This is the first one, the second, and the third that I said it was in Farsi. No significant pain relief, even in infectious cases, was observed when antibiotics were prescribed. This is why ADA and AAE do not recommend to prescribe antibiotics postoperatively just to manage the pain. So reserve it for immunocompetence. Other factors that might affect the results is one, preoperative pain, because different cases with different apical diagnosis were included in this study, and if the authors wanted to just make some sensitivity analysis based on different apical diagnosis, they had not the population they may need. Maybe more studies we need with this implication that the apical diagnosis should be just noted, because as I said, the cases included in this study were sometimes normal, sometimes infectious, and this may confound the results, and also the preoperative pain. For preoperative pain, they try to have a sensitivity analysis, but for the apical diagnosis, as they mentioned in their article, they could not because of the sample size. And the level of evidence in this study was assessed, and no significant threat of inconsistency and heterogeneity was observed. Some degree of imprecision because of the sample sizes, and moderate to very low level of evidence was the overall level of evidence in this NMA. And the authors suggested for future studies that because risk of bias in most of the studies was due to randomization, allocation, concealment, outcome measurement, outcome data, and sample sizes, try to focus on these domains, and please do the trials concert-based to avoid this bias.
But because we are going actually almost to finish everything, and thank you very much so far for your very nice presentation. I have another question from Mariam about the preapical disease or apical diagnosis, as you mentioned, because this is one of the variables. Other studies so far show that very similar to preoperative pain may have some effect on predicting post-operative pain. I mean, when we don't have any apical periodontitis, we are not expecting to have very high possibility of post-operative pain, and very similar to preoperative pain. However, in many of the cases, having preoperative pain combined with apical pathosis. So how can we separate these type of variables from each other? And also, as we already discussed that when Professor Sunai mentioned about the behavior of the patient and patient-centered idea, that multivariability of pain studies. What do you think about the diagnosis of preapical pathosis prior to initiation of the treatment and the effect of this variable?
Now, of course, we could not, the issue is that we faced in the included studies is that the data on the periapical diagnosis was underreported. So some of them may have mentioned that they had normal periapical diagnosis, others they had like various types of patients with apical periodontitis or normal, like even the included population within a study itself, the data was not reported separately, and therefore we could not investigate the effect of periapical diagnosis on the outcome. Now, of course, we may predict that more pain may be seen because as well the periapical diagnosis or the periapical inflammation may contribute to post-operative pain, but we could not come with a concrete conclusion that whether to consider it as a significant factor or not. And therefore, for future trials, we always call for authors to first have to be more transparent when it comes to reporting their results, as well as to report the results in detail. So reported according to the population. How many patients did you have with this current diagnosis, and what were the outcomes? Because reporting the data in a manner that allows the conduct of a meta-analysis or a network meta-analysis will allow us to estimate the overall effect of such factors.
Yeah, thank you very much. So in that case, one of the reasons of this networking is to have this type of conversation with each other. So if in the future one of us is going to do a clinical trial, we may ask Mariam and her team to help us. So APEC can be, or educational committee of the APEC can be the center of this type of guidance and collaboration with each other. So why not when, for example, some of us from Korea, from India, from Turkey, from Iran wants to run some studies, contact Mariam, and that can be through APEC, and ask her for her guidance for how to write it, how to run it, how to set it up, and think about the methodology prior to initiation of that. And I think Sanjay is going also to add something to that. Sanjay, please. And then Professor Ibrahim. Yes.
I wanted to bring another point. It is very common amongst dental practitioners in India to prescribe antibiotics along with NSAIDs post-operative. And I was giving a lecture in another forum, and somebody asked me, is there enough credible evidence to disapprove use of antibiotics? And I said, yes, there is a statement from ADA or AE. They said, is there enough evidence? So I went through the literature. There are not many clinical trials which have used antibiotics for post-operative pain. And most of the meta-analysis says that there is insufficient evidence to approve or disapprove use of antibiotics. So do you suggest going for a consort-based randomized clinical trial regarding use of antibiotic on post-operative pain along with NSAID?
Professor Miglani, before Mariam is going to answer this question, I want to add something to that, and Mariam is going to conclude. What am I going to say when Dr. Andrabi mentioned something about the biological consideration? I mentioned that the important thing is evidence. However, before we go for evidence, we need biological consideration as the background. If we don't have enough biological explanation for the use of any medication, there is no point, and it is not ethical to run any study. So therefore, for some sort of comment, I may say that if I'm a member of the ethical committee, I'm not going to approve any study that they want to use antibiotic just for the sake of the pain control, because there is not enough biological background to run such a study to produce evidence for the future. What's the point? So we need first to have that, then we need evidence. So this is the balance between these two important things. One is biology, one is background knowledge. The second one is evidence. Evidence is very blind. I would say that. Evidence is blind, but to go to this blind hole, we need background knowledge of the biology, obviously. Thank you very much for the comment, and I'm sure Mariam is going to conclude after Professor Abu Tahun at his comment. Professor Ibrahim, please.
There are two very important things I want to emphasize. I have noticed that there is something very important missing in the whole discussion during this almost 2 hours discussion. First of all, immune responses in endodontic therapy or during therapy. I have learned this when I was a postgraduate student from the literature of Professor Turabinijad. Any one of you can go back to these articles. He will understand and realize something extremely important, that the root canal can act as a pathway for sensitization of the host, of the periapical tissues of the human body. And after that, we are going to have some immunological even delayed responses that can interfere even in selection of a treatment necessary. Because in such cases, antibiotics are not effective, just because Dr. Sanjay mentioned this, because this is an immune response. I don't want to go further in this. I have learned a lot from Dr. Turabinijad to this, but this is the first thing, the immune responses or the hypersensitivity reactions during and after root canal treatment, which has nothing to do with inflammation. This is one thing. The other thing, and I want to conclude with this, which I think is very important, is that selection of painkillers in dentistry and endodontics is random, is experimental, like selection of many things in dentistry and in endo, such as antibiotics, antiseptics, irrigants, biomaterials. The fact is that this is very random if we take a look. Why? Because there are things that play a significant role in this. For some people might be not important, but habits play an important role. Previous experiences. I can see this materials works in my hand. This is why dentists are resistant to any new technique or any new material, because they used to use this and it works. And then you come to tell me that you have to use this, this is better. This is why they are resistant. So in my humble opinion, I think all procedures we practice in endo or in dentistry should be supported by elite literature. This is number one. They should be supported. But the second thing, which in my opinion is also important, is that because without evidence, this should be just an opinion, yes, but we cannot also ignore the common sense. What I don't know, Dr. Mohammed, you might call it anything else, but the common sense also plays a role, plays a very important role, and we cannot ignore that. So we have to find a balance between.
I do agree with you, Professor Ibrahim. I think your comment is absolutely true. However, at the end, evidence is going to justify all of this. Experiments, opinions, expert opinions, all of them, I do agree with that. Biology as well, but we need evidence to confirm that. We need those background and then go to evidence. Before I ask Fatima Batul to speak, because she raised her hand, I'm going to ask Mariam to add any comment about that, and then we go to Fatima Batul. And also there is a question in the chat room about the use of NSAID and paracetamol acetaminophen simultaneously at certain interval. Is there any evidence in this regard? Mariam, please.
Thank you for all your comments. I totally agree with you. Now, when it comes to the expert opinion and the clinical judgment, now, of course, both of them, first, when it comes to the hierarchy of evidence, actually, expert opinion is considered to be the least reliable because it's not based on any evidence. And meanwhile, randomized clinical trials and meta-analysis, systematic reviews, this represents the highest level of evidence. Now, of course, their results, however, they should be they should come along with the clinical judgment, because you need both of them, evidence as well as your clinical judgment, in order to have an evidence-based practice. So yes, and that's a very good point, that there is an immunologic basis for this type of pain, and patients actually work with hyperalgesia, so they have higher pain response to even the lowest stimulus, and you should always put that in mind. Now, when it comes to antibiotics, the reason we give antibiotics is that to fight an active infection, and therefore it's recommended when patients are showing you systematic symptoms, so high fever, malaise, that's when you want to prescribe antibiotics. However, just giving it for the sake of pain relief when you already have other pain drugs that are indicated for pain, but antibiotics are not indicated for pain. They're indicated for infection. The fact that during endodontic treatment, we're actually removing the infection from patients. We're removing the infected pulp. We're eliminating the bacteria. So there is no basis. And as you said, Dr. Nikufar, that the biologic basis is not there. So why do I need to conduct a trial when I know it's not for the sake of pain? Now, of course, unless if my population is representative, if my population is showing symptoms and like it's ethical to administer to them antibiotics, then yes. Otherwise, even though if the patient, like we can always have delay prescription, especially that if the patient does not have right access to care, but then only we have to educate them, only if you develop your symptoms, then take antibiotics. Otherwise, like we have antibiotic resistance that's increased, and we do not want to increase the risk of patients from suffering that. And the final thing, as you said, Dr. Nikofar, like frankly speaking, we receive, I work as well as I volunteer as a reviewer with the Journal of Endodontics, and I can't tell you how much papers we receive with a very low quality. And I feel super sad when we have to tell them, no, we cannot publish it. Well, it's either the quality of the paper, their protocol, the risk of bias, or even the question is just repeated. So not enough literature search was conducted in the first place, that they miss very important papers, and it's a waste of resources and a waste of time as well. So of course, there should be like higher education, there should be proper research being conducted so that we don't waste our resources, and at the same time we invest in the questions that are there. So why, for example, to investigate antibiotic or to go and investigate the efficacy of NSAIDs when NSAIDs are shown to be effective? So instead of conducting a whole trial to investigate NSAIDs, okay, have NSAIDs as a comparator and investigate, for example, other drugs that we're still questioning or we're still looking at their effect. So all of that, it has to be properly researched and properly studied before the conduct of trial. And I'm more than happy to help along with my team. Dr. Amira Zarbazou is a very big name, and he taught me all the bases of evidence-based dentistry, and he has multiple papers on evidence-based and the proper conduct of trials and how to critically appraise, which is, I think, is a very important element to teach even undergraduate students to appraise their papers, not just to read a paper randomly, PubMed search, this is on this type of drug, okay, I'm gonna take that drug and work with it. But you need to learn how to appraise and to judge on the quality of paper before taking their recommendations and implementing it in the clinic.
Fantastic, Mariam. Thank you very much. Fatima Batul, please go ahead. We have just 6 minutes to finish the session.
Okay, thank you very much once again for this very lovely presentation. I enjoyed every commentary, and every commentary was really helpful in conducting future researches. The thing is, I just wanted to add something to Dr. Ebu Tahun's words. He mentioned about prescription habits of the dentists. So we conducted a questionnaire in 2013, and it was also included in the international, in European Society of Endodontology's antibiotics guideline. So we asked about 1,300 dental practitioners about their prescription habits and what they prescribe for patients who come with pain. And we found that Turkish dentists prescribe a lot of augmentin. And we added augmentin, and we also added another section saying amoxicillin with clavulanic acid. And they just ticked the augmentin part. Why? Because GlaxoSmithKline works really hard in Turkey, and this is a habit that the Turkish dentists get used to. So sometimes the dentists even forget what it is inside the drugs, but just remember the generic words. such as Augmentin or such as Apronax, you know. So this is very important also. And I totally agree with Dr. Ebu Tahun about the common sense. Unfortunately, sometimes the general dental practitioners and sometimes us too forget the data and sometimes just repeat ourselves with what was coded by, you know, by the media and everything. So once again,
thank you very much, Fatima. I think there are just 2 more slides. Fatima Hamidzadeh, please go ahead, show that to us, and we end up with some talk from colleagues. Fatima, please.
Yes, of course. And the author suggests to find the best therapies for patients who can't take NSAIDs because they think that about other patients we have something to say. And the conclusion part, I want to read it word by word. Very low to moderate quality evidence suggests that NSAIDs or NSAIDs plus acetaminophen administered after non-surgical endodontic treatment lead to a clinically relevant decrease in postoperative pain for patients with irreversible pulpitis or pulpal necrosis and are the most effective treatments available. Postoperative corticosteroids or opioids did not significantly decrease postoperative pain. I think these 2 were the take-home messages of this article. And thanks for your kind attention.
Thank you very much, Fatima. Please unshare the screen because we want to see all the participants. Okay, thank you very much, everybody. For myself, that is a very, very informative session. Thank you very much for the support that we have received from APEC and also from the Tehran University of Medical Sciences. Both of you help us to arrange such a things. And I need actually to say my special thanks to Educational Committee of APEC, which starts by the initiative of Professor Abu Tahun and now leads with the leadership of Professor Sanjay Miglani. Thank you very much. With this infrastructure and the networking, we can discuss a lot with each other, much, much more than the way that we just can write something and publish it. Mariam, you're superb. Thank you very much. And usually, as a habit, we are going to give mark to our postgraduate students who present these sessions. So, Fatima, okay, I leave it to Professor Abu Tahun, Professor Miglani, Professor Sunai, and Professor Zagar and others that I can see, Professor Rahimi, to help me to give which mark to Fatima Hamidzadeh. She is going to pass or she still needs some work. I think Dr. Bakhtiar is going to add something. Please go ahead.
Excuse me. Before going to that, we had the same question in the chat box. I want to clear that. Mariam, previously we used to prescribe this regime like a flexible plan every 2 hours. Just please clear that. What is your recommendation according to your research? Are you going to prescribe, you know, the acetaminophen and ibuprofen simultaneously, or like in a flexible regime as we had previously?
No, again, we were limited by the fact that we could not investigate the effect of the different types and the intervals, but what we had in our paper was only a single dose post-operatively. So these results that you see were based on post-operative 1 dose administration to patients right after the treatment. Now, the current recommendations, and therefore you need to follow the current recommendations, which states that if a patient is having mild pain, just give them NSAIDs, 200 to 400 milligrams ibuprofen. And if the patient is still getting some pain, then you can as well keep the same ibuprofen. So you need to educate the patient on the intensity. Was it mild or was it moderate to severe. If they are to rate it from 1 to 10, for example, is it more towards 7, 8, or 6, or is it like 2 to 3 out of 10? Once they can come to a judgment to this conclusion, then it's better to keep ibuprofen. Otherwise, if it's moderate to severe, ibuprofen plus acetaminophen, and to follow the recommended dosage, not to exceed the maximum. So you need to tell them the maximum of ibuprofen 300 to 3,200 milligrams, and and the acetaminophen. So not to like every 4 to 6 hours, but do not exceed the maximum dosage. And of importance, conclusion as well, pain tend to decrease whether you give a drug or not. So that's what we found, and it agrees with the previous literature. Within 2 days, up to 80% of the pain would actually disappear, and in 1 week, the pain is gone. So whether the patient can take medication or not, we can simply tell them after 24 hours, 50% of the pain will disappear. So whether you take a medication or not, it's just that we're trying to improve patient experience. So if they're feeling the pain, and they may take a drug, but then we have to always reassure them that the pain may disappear. If a patient was still complaining of severe pain, for example, after 2 days, something is wrong. Maybe they're just having like flare-ups, or they need to come back and be checked, because normally this pain should be eliminated by at least 50% in 24 hours.
Okay, thank you very much. So it's time to give mark to Dr. Fatima Hamidzadeh, our postgraduate student. I leave it to you guys. Sanjay, Haki, Ibrahim, please go ahead. Professor Ibrahim.
I think.
Yes, please.
I think Fatima passes with flying colors, but I think Mariam was the rock star today. It is such a pleasure to be here, because you see many old friends like Fatima, Hengeme, Haki. We usually don't meet now because of COVID. So it was a pleasure meeting all of you, and Fatima, you did a very good job. Great.
Is she? Okay. Professor Ibrahim, do you agree? Should we give her maybe B, just B plus, A plus, A, I don't know, D?
Yeah, but I want to add something. If we give her whatever mark we give to her, we give you a distinction, because you have created a legacy in the educational committee. You have transported and transformed APEC to a really educational platform, which is special for all international societies and endodontic societies. Really, I'm really very thankful for the period we worked together in the educational committee, and I'm sure this legacy will continue, will be better. A big thank you to Dr. Mariam, of course, to Dr. Fatima, and without you, nothing would happen. This is why my biggest thank you goes to you, Professor Nkufar. Thank you all.
Thank you very much. Thank you very much. So we put our hand together first for Fatima Hamidzadeh. Thank you very much, Fatima, for your time. I know you spent a lot of time to understand this very difficult publication by Mariam Zanjir. And Mariam, we are very proud of you, very proud of you. As Sanjay mentioned that, you are our star today. You are our star today.
Thank you.
Really
it's actually
read
my
your articles previously. I really enjoyed from them. But today you showed that you are a very, very important asset for the future of endodontics. You are a young researcher, and future is yours. And we are looking forward to receive more and more precious articles from you. And I'm happy that APEC is going to receive your very good support about writing the methodology for our researcher. And it is our job to communicate with you now and ask you for your help for that. Thank you very much. I don't have enough word to say that. And thanks for accepting our invitation. Please, everybody, put our hand together and clap for Dr. Mariam Zanjir. Thank you very much, indeed.
Thank you. No, it's actually my pleasure to join. I'm always happy to help, and that's the whole purpose and the goal of these publications. We wanted to reach as many clinicians as possible. And Fatima, thank you so much for the preparation. It was actually a pleasure and very nice to see my project from a different perspective. You did a very good job. Keep going, and I wish you all the best in your graduate studies and your practice afterwards.
Thank you. Thank you very much. So I give Professor Sanjay Miglani the Dean of the Educational Committee of Asian Pacific Endodontic Confederation and the past president of the APEC as well, to give us the last word and end the session. Sanjay, please go ahead.
Yeah, thank you, Dr. Nikufar. On behalf of Education Committee of APEC, I would like to thank Dr. Nikufar for organizing this program. Thank you so much. And my congratulations to Fatima. She did a wonderful job. And, it was such a pleasure to read this article, and I could get 3 ideas for my postgraduate students. We are running some randomized clinical trials already. So, Mariam, you be sure that we will be disturbing you for many future projects. So it was a pleasure to see all of you, and we hope to see you again soon. Thank you, Dr. Nikufar.
Thank you very much, and goodbye, everybody, and see you in a month, hopefully. Goodbye.
Thank you. Bye-bye.
Bye-bye.
See you. Bye-bye.